Pyogenic flexor tenosynovitis. As we discussed before, the flexor tendons are in tenosynovium. These can get infected. The cannibal signs are known to identify these sort of infections. There is number 1, fusiform swelling. Number 2, flex posture. Number 3, tenderness at the palpation of the tendon sheath. Number 4, painful at passive extension. If I see such a patient in A&E, I would have a high suspicion of flexor tenosynovitis. I will assess the patient, take a pertinent history, do an optimal examination. Addressing and finding those cannibal signs is important, and documenting it. I will not give the patient antibiotics. I will give the patient adequate analgesia. And if the lab markers does show increased CRP and WBC count, or if it's evident, I would plan for operative intervention. The operative interventions are of 2 types. First is minimal invasive technique, which consists of giving a small incision at the level of A1 pulley and another incision at the level of A5 pulley, and then from proximal to distal, washing it out with a syringe. This is possible to succeed within 24 to 48 hours. Once this is debrided, I will not close the wound and will start the patient with adequate antibiotics. If I'm not able to wash it out optimally, or there is a delayed medical attention is given, then in that case I will prefer to do brittle zigzag incisions, open the tenosynovial sheet, debride it optimally, wash it, and then close the wounds and assess the patient in the theater after 24 to 48 hours.